da chi gyd a croeso i Bwrdd Iechyd Brifysgol yn Iron Bevan. Good morning everybody and welcome to this special meeting of the Iron Bevan Health Board. I'd like to start with a couple of introductory. Could I please express our condolences on behalf of the board to Richard on the death of his mother. We're really sorry to hear that that has happened, and to Peter Carr on the death of his father. We've had to say a hopeful temporary farewell to Emrys as he's taken up his position as the interim chair of an Cwmtaf Morgannwg University Health Board. We wish him every success, and I know we will all support him in his endeavours there. And then finally, and not least, to Judith, to congratulate her on her interim appointment as the Director General for Health and Social Care and the NHS Chief Executive for Wales. Yeah, we will, of course, have a leaving do for you, socially distanced, of course. But I think I'd just like to say, you know, I've known you for a very, very long time. You've always shown exemplary leadership qualities since you embarked on your career. And you've been particularly visible during your role as the Chief Executive of our Health Board. You've led the team very well indeed, particularly in such very difficult circumstances, and your judgment has always been very sound, balanced and evidenced. We really wish you every success as the Director General for Health and Social Care. And we've got every confidence in your ability to undertake that role conscientiously, effectively, and really well. So thank you so much, and congratulations to you. Thank you. Apologies for absence. I've had apologies from Keith Sutcliffe, Sarah Aitken, Peter Carr, Gemma from the CHC, James Quans from Internal Audit and Audit Wales. I don't think we have any other apologies, do we? Okay.
No, I haven't been given any others, Chair.
Thank you. Any declarations of interest? No. So items for decision. The South East Wales Vascular Network business case is in front of us today. We've had a couple of board briefings about this as it has been progressing and as the decision has been taken to proceed with a vascular network for South East Wales. This has been debated consistently over the past large number of years. And we have been in discussions with the CHC about the consequences of this for some considerable time. But I should like to hand over to Nicola to take us through the overarching report that she has provided, which is really helpful. It's very succinct and it points out all the major things. And then I'll come to the business case itself and we'll invite questions. Okay, Nicola?
Yeah, thanks, Chair. And as you mentioned, everyone's aware we've been working really hard on producing a programme business case to support this regional reconfiguration of vascular services. You know, developing a more robust vascular network for South East Wales, very much based on a hub and spoke arrangement with University Hospital of Wales being the hub for all vascular surgery, is supported by spokes in each local hospitals in Cardiff and Vale, Cwmtaf Morgannwg and AB. And as you said, this went through a robust process with our CHCs, a robust engagement process, and they've supported them from all health boards, which includes Powys as well as a key commissioner. So I'm pleased to finally share and seek approval for the programme business case for the South East Wales Regional Vascular Network, so that we can progress to that next stage, which would be an implementation planning stage involving a robust readiness assessment process. So I thought, should I draw out some of the key headlines and issues for consideration, Anne, if that's okay?
Yes, please.
So firstly is just reinforcing the case for...
Oh, Nicola.
Sorry, I just clicked my mute button by mistake. As it says in the paper, vascular deaths account for over 40% of deaths in the UK, so it's a significant issue. But this is very much a case driven by sustainability and the fragility of services in the future, potentially due to workforce availability and ability to recruit in the region. Whilst we currently got a relatively sustainable service at the minute with our local service, Cwm Taf Morgannwg had already had to centralise with Cardiff as a result of having no interventional radiology support, and we've already centralised our own out-of-hours interventional radiology across the region. And if you look at the Vascular Society for Great Britain and Ireland and NCPOD, all of those guidelines and best practice support a centralised model for a population of our size, and is very much the model that is in place across the majority of the UK. And the model that we've set out for the future aligns very much to those recommendations. As I highlighted on page 3 of the report, the cover report, you know, the aim of the reconfiguration is to improve outcomes for patients through the hub and spoke model, and providing an improved locally medically led rehab service as part of the pathway. The workforce and service standards could be maintained by providing the vascular surgical service with appropriate critical support 24/7, a much more viable rota maintained across consultant and training grades in vascular surgery and interventional radiology now and in the future. And I know one of the issues James has kind of highlighted as well is there's potentially significant benefits for the training of vascular surgery under this new model, and co-location with critical services is maintained as well. So it's just really important to re-emphasise kind of that case for change and what we'd expect in terms of the benefits. And linked to that, as a regional programme board, we have discussed this issue in quite some detail around how important it is that we understand all of our starting points in terms of our current process and outcome measures, and monitor those very closely as we move into a centralised model to ensure that we see improvement and not any deterioration, so that we can move towards a more upper quartile position in the UK. We're all all deliver relatively well across the UK and based on current audit data, but there is room for improvement, and we are keen to make sure that this new model does deliver improved outcomes for patients. So that'll be a key issue for us to monitor going forward. The second area is just to pull out the financial implications of the case, which are not insignificant. As you can see there's a lot of detail in the case, and we've summarised it in the cover paper. There's an overall cost for the new service of £5.6 million. Primarily, that is the additional cost of Cardiff and Vale delivering the additional activity in the hub. There are some costs associated with setting up a network and a centralised model, and there's some non-recurrent costs in there, but they're relatively small. But there is, and of that 5.6, 2.7 relates to an Iron Bevan Health Board share. And of the 2.7, there is an opportunity for us to mitigate 1.4 million of that, just by targeting the cost that we should be able to release or redirect in terms of theatre, wards, and obviously our consultants spending time in the hub as well. This would be a key area of focus for us going forward, because it's really important that we get a clear audit trail of how we use those resources that will be released as a result of this centralisation. And there should be plenty of opportunity for us to do that in the context of the recovery agenda we've got and some new investment potentially coming our way. But we need to make sure that we make the right decisions on that and redirect them appropriately. There is a small increase in activity across the region, but it's not that significant. There's an extra 88 cases in total in that overall cost. So I think that's all I need to say on the financial side. Another issue to pull out, which is mentioned in the paper, is theatre capacity. This has been a key issue for discussion for our clinicians who, as part of the regional discussions, felt we should have 8 dedicated lists for vascular. There's been ongoing discussion, and 6 theatre lists are provided with 3 flex lists. This offers flexibility to manage the situation more efficiently, but sharing that with other specialties. So this is an area that we've agreed will need to be closely monitored to make sure it doesn't compromise access for vascular surgery, and to see how that model works. We did have a peer review as part of the business case development, by colleagues in Bristol, Bath and a few other areas. And theatre capacity was an issue that was raised as something to kind of keep an eye on. And I know the discussions with the clinicians and the medical directors of the health boards has suggested that maybe it would be useful to get a Vascular Society review of the case in parallel with us progressing now with the implementation stage and the readiness assessments, just to give us some further advice as to the theatre capacity and the theatre model, and other aspects of the business case while they're looking at that. Workforce is a key area of priority, making sure that Cardiff can recruit the posts that we need. Obviously, staff consultation has been ongoing and will be ongoing to make sure people have got the opportunity to be over to Cardiff for those who would be interested from the other health boards. But there is still quite a big recruitment requirement for Cardiff, particularly around ward staff theatres, and they have been making good progress on that, but it is a key area. And one that's outstanding is the junior doctor provision, and there's ongoing discussions with HEIW around what that training model now looks like as part of the region, and if it's adequate to support the current model we've got. And then the last point is around timing. As we now, assuming we can achieve approval of the business case, and Cardiff and Vale and Cwm Taf Morgannwg and Powys all approved this case at their boards in the last few weeks. We will undertake a comprehensive readiness assessment, as I mentioned, and try to agree what an appropriate go live time would then be based on that readiness assessment, but also in the context of the broader system risk that we're all managing with. And therefore there would be an ongoing review of, that balance of risk of vascular services and the wider system. Current indications we think is likely to be more after winter, but that's something that we will continue to monitor closely as part of that work. So that's all I was going to say, Chair. So the recommendations of the report to the board is to approve the South East Wales Vascular Network business case, approve the additional £1.5 million net revenue cost investment in vascular services, but noting the action that required to release costs or redirect potentially of around £1.4 million. There is also mentioned in the case there's a separate capital business case that's in development for the hybrid theatre at UHW. That's just been to its investment infrastructure board at Welsh Government, and is a key requirement for us, for our clinicians to know that's all in hand for the future. And just to note the readiness assessment process that we'll go through as part of the implementation phase to agree an appropriate go live date. Is that okay, Chair? Thank you.
Thank you very much, Nicola, and thank you and the whole team for the enormous amount of work that you have undertaken in order to produce this business case and to progress an idea and an agreement that has been outstanding for a number of years. So you've worked extremely hard to get us to this place, and I must commend the hard work and the intelligent way in which Victoria, as the project manager, has managed this difficult situation, because there's been quite a lot to sort out between the teams, and you and Victoria have done extremely well to get us to a place where we can consider the business case. So thank you very much to you and your teams. Paul?
This has been a very, very important issue, which is, as you said earlier, Chair, has gone on for a considerable period of time. What I, as a health board member, what I've been impressed with is we've had a very detailed case that's put forward. There's been regular reviews on this particular issue, because we've had some concerns, but they've all been addressed. I think all options have been considered, and the regional hub and spoke model is supported by all the people involved in the region, which I think is incredibly important. And I think the fact that rehabilitation is going to be delivered locally, I think I've got that correct, Nicola. Yes. I think it's something which will be important to patients. And at the end of the day, I think, as was said, the outcome is to look at expected improvement for patients, and the important thing for our board will be to monitor this. So I have no hesitation whatsoever, Chair, in firmly recommending the proposal, because I think it will make a difference, and will make a difference for the best for our patients within our area.
Thank you, Paul. Shelley?
Yeah, I was echo what Paul has said. There were just there was one point I just wanted clarification on in the cover report, Nicola, and I think you've covered it. But on page 4, there's a couple of sort of bullet points. It's the second one down, and it says that the Health Board executive team has articulated that a go-live decision cannot be made without the receipt of a number of assurances on clinical and operational safety and delivery. Now, I'm assuming that those are the items that you've raised in the cover report specifically. So, am I right that they're not nothing different in that particular bullet?
No, I don't think so, other than, when we do the readiness assessments, we will go into a lot of detail. So I gave a couple of high level examples, but, is the workforce in place?
Yeah.
Have we understood the operational policies and how patients will flow if they present in different places? Is the IT and informatics all worked through? So it'll be a very detailed readiness assessment, and it's quite interesting. Our own clinicians have to go in through some of the work we did on the preparation to go into the Grange, and the detailed, the level of detail we went into around readiness. I think, they are very committed to making sure, that we've got that thorough approach, recognising it's a smaller project, but rather than say, oh, let's go in and, hopefully it should work. We are very clear that this would be a detailed piece of work.
No, that's great. Thank you, Nicola. And my other query I had was around the costings, but you covered that when you did your introduction, your presentation. So thank you very much.
Thank you.
Thank you, Shelley. I think it's really important that we consider how the readiness assessment might be undertaken, because we need assurance that the from Cardiff and the Vale particularly, that the estate and staffing issues that are mentioned within the business case are not insurmountable, and that the IT does talk one to the other. And I would suggest, it might be a bit premature in this discussion, but I think it would be really helpful if we had some sort of external verification of the readiness assessment as we go forward, because that'll give us additional assurance, which might be invaluable. Pippa and then James.
Yes, thank you. And first of all, I want to say that I fully support this, because I think it's something that's going to lead to much better outcomes for our patients, and that's what we want at the end of the day. I think you've probably touched on this already, Nicola, but it's just for clarification for me, really. We obviously need to be monitoring some of the sort of key metrics, and there's the time really that what's the outcome going to be, and by what time are we going to achieve that? I think are the things that at the moment I feel we don't have the detail of that. The other thing is, I think the involvement of the Vascular Society is probably going to be really important, because they've plainly done a lot of work in this area before with other health boards, and so we may as well not try and reinvent the wheel, I guess. But having their oversight, I think, will be invaluable. But they're just the two things for me are around kind of what's going to improve and by when, and ensuring that we have the Vascular Society involved with this. So thank you, but I fully support it.
Thank you.
Can I
just start, Nicola? Who's going to be monitoring the outcomes, and to whom will they be accountable?
Yeah, well, we'll, as part of the business case, there is the establishment of a network team.
Yeah.
We will have a vascular network manager and some support teams. So we try and to almost mirror the way that major trauma has been set up, where there's like an operational delivery network, which is separate to the delivery kind of team as the hub. And therefore they will have a kind of more objective role that kind of will follow the implementation of this case and monitor the outcomes and report regularly. We haven't quite worked through the detail of that, reporting structure and kind of what the report looks like, but that will be done as part of the implementation planning stage. But that's where I see that role happening, and will be accountable to the kind of the host of the network, which we're still working through.
Thank you very much. That's most useful. James?
Yes, thanks, Anna. It's really answering Pippa's question, and also, Paul has raised the same question in previous board meetings, so I wanted to make sure I had a bit of an answer when I came. And the medical directors and I have spent quite some time chatting about the benefits realization of the network. And, you know, from a clinical point of view, it's a slightly different metric from normal, because actually at the moment, because of the fact that Cardiff and Cwmtaf Morgannwg have already combined, their results are good. Our results have always been good. This is a situation where we need to do this to keep our results as good as they are. Now, there may be additional benefits, but we're starting from the right point at the moment. And, you know, like many areas of medicine, vascular surgery is progressing very rapidly, with a lot more being done by interventional radiologists. Interventional radiologists are an extremely difficult to recruit group, and the newest generation of vascular surgeons expect to work in a centre with significant interventional radiology input. They're a very codependent group. We will not be able to recruit those new vascular surgeons unless we go ahead and implement this model. So we are, one of the benefits is that we will continue to be able to recruit and future-proof our services. You also asked about this, well, and then the other tangible benefit that I don't think we've made enough of, that Nicola alluded to, is the only part of our kind of wider service that is not exemplary is the training of vascular surgeons. So the Vascular Society surveys their trainees annually, and as medical director, it was quite reassuring to see that our local consultants are rated amongst the most highly in the UK for how supportive they are and how good they are for training. But the access to training is not good. So we've got all the right people, but we're not doing enough of the very complex procedures for trainees who are not working in a network to do the stuff they need to do to be the fantastic vascular surgeons of the future. And that, I think, is probably one of the things that should be fixed by the network. So as part of the implementation, I asked if we could look at doing that detailed bit of work around training to ensure that if Paul asks me the same question again and you ask me the same question again, we can actually say, well, this is the benefit that we expect will accrue to training. And then there's obviously there's the sustainability bit, which is harder to measure. We already have experience in South East Wales of patients with time-sensitive conditions potentially not being managed as well as in other parts of the UK because of issues related to conveyance between centres. And that is probably one of the biggest concerns of our clinicians, that they don't want to see our patients having poorer outcomes because they're being conveyed to another centre. So when we were, you know, in the run up to this meeting, when the medical directors have met with the clinicians, we have agreed that we need to have much more detail about the governance arrangements that will be in place at go live. And there's a line in the sort of briefing paper saying that outcomes will be measured continuously. That was not the initial plan. The initial plan was to measure at 3 and 6 months, but I didn't feel that that was timely or brisk enough. If there is a single patient who has a worse outcome because of this than they would have before, we need to know about that on the day it happens. And there is a broader bit of work going on looking at how we can mitigate the sort of well-publicised issues that WAST is having with its sort of operational performance, and what we can do as a health board, both to support WAST, but also to put in place measures that are within our gift to make sure that our patients don't suffer from this. Because what I don't want is to be having a conversation in 6 months about delayed patients going to Cardiff and Vale. It's predictable now, so we need to think about something to deal with it. So the sort of short answer, Pippa, is we need a really good governance framework that needs to be managed by the group that Nicola's highlighted, the implementation group. One of the real benefits will be in training, and the other benefit will be in the future around sustainability of excellent vascular services for the population of South East Wales.
Thank you very much, James. That was really clear, and we'll take some of these issues up later in the discussion. Tish?
Thank you, Chair. Just to say, yes, I support this business case. We have talked about it and agree with comments already made. I'd just like to change the focus slightly for a moment. We had comments just earlier about the spoke part of the model, and rehabilitation will happen locally. But I'd just like to make the point around prehabilitation and how important that is, and all of the foundational work that we have in our Building Healthier Gwent in helping to prevent individuals getting to the stage at which they need these most acute of services. So I'm hoping that with the implementation of this, that we can have a reinvigorated energy around that area of our work, and to engage the third sector in encouraging people to support their health at that foundational level.
Thank you, Tisha. Most important point, and one which we shall monitor as we go through the implementation of this and try and succeed, as James has outlined. So thank you for that. Are there any further discussions or comments? Concerns anybody has? Glyn?
Yeah, thanks, Chair. Just sort of one final one. I think most of the points that I was going to raise, other people have actually covered very eloquently, so that's really helpful. Just to sort of, I suppose, make the board aware that Nicola sort of raised the issue of the costs that we'd be looking to mitigate within this plan as part of centralising the services, and we will sort of over the next few months work through what that looks like. So I thought it was just important for the board to have a little bit more of an understanding of what we're going to do around that. So mitigating the costs can mean either by changing the way the service is delivered more centrally, that we don't incur some of those costs locally. So that's the one option. The other option is that potentially we can use some of those wards and theatre resources for something else, but it would mean that we'd need to secure funding separately for that. So for instance, as part of our recovery planning work, we may choose to use some of those theatres and ward resources in that way, and to fund those costs through sort of recovery funding. So we'll be working through the plan as we go through the next few months, but I thought it was important probably just to give the board that information around how we might try and mitigate some of those costs. I think the other points I was going to raise have all been covered off, so thank you.
Thank you very much, Glyn, and thank you for that assurance. Paul?
Just to ask about the monitoring arrangements, just to unpick what you said earlier, Nicola, with regards to where this is reported to, because obviously it's going to be important that we get information at the Anira and Bevan sort of situation. So will that go to our Patient Quality and Safety Committee, or how will we engage in that monitoring, and what will be the monitoring arrangements, or is that still to be worked out?
We'll work out the finer detail, but we will ensure that it's part of, routine. So any incidents would come up through patient quality and safety. Some of the national audit or the quarterly audits can come up through that quality and safety, and some could be potentially featured in our normal performance report. So depending on the measures that we use, we will ensure they reported at the right frequency to the right committee. James looks like he wants to come in on that point as well.
Yeah. James?
Yeah, and I've already discussed with the clinicians, as Nicola says, the detail needs to be worked out. But I think one of the biggest risks in this model are delays in conveyance, which we know will lead to worse outcomes. So I've asked that we develop a dashboard of time-sensitive conditions and monitor time from presentation to time of arrival in theatre. So we have a similar metric for myocardial infarction, and I think we need to do the same thing here, because the vascular surgeons tell me that as you might expect, that delays in surgically addressing ischemic limbs leads to significantly worse outcomes with the leg, just as it does with the heart. So I want to measure that from day one. So,
and could I just ask, Chair, in terms of then informing the patients, how will this now be sort of, what's the cascaded or whatever the key word is, so that patients are available, will know what's going on where, and what's available where, what's the next stage in terms of the communication plan once, because it looks as if we're the final decision makers in all this. So if it's gone through all the other boards and we're the final board and it's all been agreed, is there a communications plan, a detailed one, to inform patients across the region?
We'll pick that up with the actual programme board. Obviously, as part of the readiness assessment and a go live plan, we would need to make sure the communication is a key element of that, in terms of making sure the public are aware of when this change is planning to happen. So it's about trying to time the communication at the right points and the right milestones. But there will need to be obviously feedback back to the CHCs in particular on our decisions on the business case and the next steps. But I think the communication plan with the public will feature in the readiness assessment and implementation planning.
And you involved the Community Health Council, so that was the next question. So I'm pleased with all you said, Nicola. Thank you very much.
We updated the United and Bevan Community Health Council yesterday on this, where we were at and some of the issues we raised today. And I think, again, we're very understanding and supportive of having a go live date that took into account the broader system pressures as well as just vascular. So they've been very supportive.
Well done. Thank you very much. Thank you, Anne.
Thank you. Could I just go back to the question of the theatres, because I know this has been an issue of much discussion. Has there now been a resolution to this, or do further discussions need to take place?
As far as I'm aware now, it has been concluded, but there's an agreement that this will be reviewed on a quarterly basis to see how things are working. And I think, as James indicated, he might come back in parallel to the implementation, getting some further independent view from the Vascular Society, I think will help settle the concerns around this, or just test whether what we're proposing is the right one. But as we stand now, we are progressing with the 6 sessions plus the flex. Is that right, James? You can see you nodding. I did give the answer, did I?
Yeah. So exactly as Nicola says, there is disquiet amongst the clinicians about, well, our clinicians around the number of theatre sessions. From the discussions I've been involved with all 3 of the centres, I think what we're planning on doing is safe and evidence-based, and part of reassuring ourselves and reassuring our population is now asking the Vascular Society to come in and do a final review of the model, which has been based on their specifications. So it is that sort of final level of assurance. So
thank you, James. That's very helpful indeed, because I know there's been a considerable amount of discussion about this, and I'm glad to see that there will be such rigorous monitoring of the effectiveness of the arrangements that we're putting in. Are there any further questions? Or can I put to you that we accept this business case for implementation now? And might I suggest that we endorse these, oh, sorry, Paul. Okay, that we endorse the recommendation made by James, that outcomes will be measured constantly, because we do need to know that our decision making is sound and implementable. We need to have a little more work done on the network, who's hosting it, what's it going to do, how does it report, so that whole governance area around the network. And I would suggest that the readiness assessment includes some independent advice, say from the Vascular Society. I think that would just give us an added level of assurance. Would you be happy to endorse that? Yes? Okay. Well, thank you very much, all of you. And thank you to the team for the huge amount of work that has been done in getting this important project to such an advanced state. And we look forward to receiving a report to the board following the next suite of meetings of the programme board and the steering group and the governance mechanisms to ensure that we know what the timeline for achieving standards are, whether or not there are any issues, and basically what a sensible, sound go live date will be. So thank you very much. Is there any further business for this board this morning? No? Well, can I thank you very much for attending this special meeting and advise you that the next meeting of the Health Board will be the 24th of November at 9:30. And thank you very much. We now have a board briefing session which will take place in 5 minutes. Thank you.